All right. So we have, let us wait for 2-3 minutes more for the people to join in, and then we'll start the session. Till then, you people can tell me something about yourself. So, Dr. Lydia, Dr. Alma, like where are you from? Where are you in the journey of AMC? Dr. Upuli. All right, we have someone in the chat. You're sitting AMC-1 next year. Right, doctor. Okay. Everyone else, please introduce yourself. Tell me something about yourself. Dr. Tarun, Dr. Sumaya, Dr. Upuli, Dr. Low. You can send your info in the chat box if you want, like which country you are from, and have you booked your exam yet, and what are your expectations out of this webinar? What do you want to know from us? Dr. Lydia is from New York. She's sitting next year. Tarun Sahani from Nepal. Tarun, you're also sitting next year? Okay. Hello, neighbor. I'm from India. All right. Other people also, please give your intro in the chat box, and then we'll start with the session. And you'll have a brief idea about how to read the context in the context of AMC exam and how to tackle questions. Lo is from Malaysia. You're sitting for the exam next month. Okay. So, Dr. Lo, have you taken any coachings from somewhere else, like some other platform or this platform also? Right. All right. So that's good. So you're here for the revisions and all, right? Nice. Dr. K, Dr. Joy, Dr. Imad, welcome to AMC Med Exam Expert. Dr. Upul is from Sri Lanka and you'll sit for the exam next year. That's great. That's cool. Okay, I think I should start with the session. So, see, when we're talking about AMC, so here we have two exams. We have two exams. What the hell is going? How do I make this work? Team exam expert, please help me out here. How do I make this pen work? Okay. So for AMC exam, we have two points. We have AMC-1, which is one exam, and AMC-2, which is the clinical exam. And AMC Med Exam Expert is giving coaching for both of these exams. And in the AMC MCQ exam, what you have to know is that the exam is time limiting. There are no negative markings. It has 250 questions and you have to attempt all. Now, some of those questions are pilot questions. They will not be marked. They will only be assessed. And the markings of each exam, each question will vary. So some of them will be high marking answers and some of them will be low marking answers. So when you do a correct answer, the next question in reflex will be a difficult one. And as you keep going on, the difficulty of questions will keep increasing till you mark a wrong answer. Then again, they will set the bar to 0. So when you are doing answers correct in a sequence, that means your score is going high. So, and since you have limited time, so I would suggest that you take care of the timing as well. Do a lot of practice and it will be fine. So now about today's topic. So I chose this topic because Australia has different health management pathways from us, from most of the countries. And that is why this exam is so unique. And that is why you need to be with people who have cleared this exam and what is required out of this exam is that this is working fine now. Okay. So what I was saying was that, yes, you have to be with people who have cleared this exam prior. And who have some idea about how to go about this exam. So why I choose the cervical screening pathway is because this is pretty unique for this country. We do not do things like in this fashion in any other country. We do not have such nice screening pathways for bowel cancer, cervical cancer, breast cancer as they are defined. And the steps are very unique in this pathway. So earlier, what was happening is that we had the pap smear. And the pap smear was done away with the Australian government, and it was replaced by cervical screening test. Why? Because in this test, we are testing for DNA of HPV. We are not testing for the cancer, but we are testing for the causative agent, which is better because we are trying to look at the source of the problem. Okay, so National Cervical Cancer Screening Program, NCSP, it replaced pap smear with cervical screening test. And here we are testing for HPV DNA. So this is one of the MCQs. What do we actually test in CST? We test for HPV DNA. And it is better because we are looking at the source of the problem. Pap smear was done every 2 years. Every 2 years. I'm really struggling with this pen thing. Med exam expert team, if you can help me, please. So pap smear was done every 2 years. Pap smear was done every 2 years. And it was done from the ages of 18. It was done from 18 to 69 years of age. Whereas the cervical screening test is done from the ages of 25 to 74. Now, someone can ask that why it is done at such a late age. Aren't we missing that gap where we could screen cervical cancer at an earlier age? So, because the cervical cancer is caused by HPV, and HPV takes around 10 to 15 years for the cervical cancer to happen. So that is why we test it at a very late age, not at 18 years of age. And the sensitivity is very high for checking out the HPV DNA. So that is why we are happy with cervical screening test. Now, what is the eligibility for cervical screening test? It is anyone who has a cervix and is in the age range of 25 to 74 is eligible for a cervical screening test. And when we talk about sexual contact in these patients, like what kind of contact is counted as sexual contact? It is not just the penetration. It is also the oral, the skin to skin, and the anal. So every sort of contact is counted in sexual contacts, because HPV can not only affect the vagina and penis, it can also affect the other mucosal parts of the body, regardless of gender identity. So even if they say that the patient is a transgender, or the patient has orientation of a different sex, or the patient is a homosexual, or the patient is a lesbian, in all those cases also the eligibility stays the same. The patient has to have a cervix and in between the ages of 25 to 74. There are some exceptions where the cervical screening test has to be done before the age of 25. So that exception is when the patient had sex around the age of 14, 15, and they were not vaccinated with Gardasil. So, yes. Is there a question? Was there is there a question, or is it just noise? Okay. So the first cervical screening test is done at 25 years of age. This is working, but my pen is not working. All right. And when to do it before 24 years of age? So we can perform it between 20 to 24 years of age if the patient has a sexual contact before the age of 14 or around the age of 14 and the patient was not vaccinated with Gardasil. Then we say that it is done every 5 years. It is done every 5 years. Now this is also not always true, because there are some exceptions to this also. For example, in immunocompromised individuals, this is done every 3 years, and because there is a high risk of getting these patients having cancer. And if it is positive, then we do not go for a reflex LBC or weight. We directly go for colposcopy. So if in an immunocompromised patient, we are detecting a HPV DNA, then we are going for direct colposcopy. So then all those patients who had a cervical abnormality previously, and now they're coming to you for screening, so they would require a post-treatment surveillance. And the post-treatment surveillance also ends up in the cervical screening category. So for example, for high-grade squamous intraepithelial neoplasia, the frequency is increased. It is happening every 1 to 2 years. And once we have 2 negative reports, then only after that, the patient goes back to the normal routine screening pathway. So 2 kinds of sample collection takes place in cervical screening test. One is the self collection, where the patient is provided the. Let me share another. Yeah. Okay. Better now. Yes. Right. So what we've done so far is we have done that the CST is done every 5 yearly. It is done from 25 to 74 years of age. The sensitivity is very high, and this is better than pap smear because we are looking at the source. We are looking for the HPV DNA. So this is very clear. Now talking about eligibility. So anyone with a cervix, please remember this thing, anyone with a cervix. Okay. Sexual contact of any type, whether it is penetrating sex, whether it is oral sex, whether it is skin to skin touch, whether it is anal sex. Then regardless of gender identity, doesn't matter what the patient correlates with, regardless of the sexual orientation, regardless of pregnancy, regardless of HPV vaccine status. In any case, we have to test every patient from 25 to 74 years of age with a cervix. Now, what happens in the cases of immunocompromised patient? In these patients, it is done every 3 yearly. And if positive, we go directly for colposcopy. Okay. What is done in patients who have previous cervical abnormalities? For example, a patient who had HSIL or maybe adenocarcinoma. In all those cases, we do something which is called as post-treatment surveillance. We'll be talking about this in a while. And it is done every 1 to 2 years. And when we have 2 negative reports, then we either put the patient into the cervical screening category again, or we stop screening them depending upon presence or absence of uterus, right? Now, about the sample collection. Sample collection is done in 2 parts, in 2 ways. One is the self collection kit, and one is the clinician collected sample. Okay. So the self collection kit is, it has a swab, and the patient can take her own vaginal sample, and then they put that swab into the solution and give it to the clinician. It is contraindicated in certain cases. So when do we do not do a self-collection kit? It is when there are signs and symptoms present. If the patient is bleeding, if the patient has discharge, if the patient has postcoital bleed, or the patient is maybe pregnant. So in all these cases, we do not go for a self-collection kit. Then if the patient has been treated earlier for adenocarcinoma, okay. Then if the patient has had a BES exposure in the womb, or the patient is undergoing test of cure. Now, test of cure is the same as post-treatment surveillance, okay. We'll read about it just now. What is post-treatment surveillance and what is test of cure? Now let's talk about the likelihood. So if you have taken a sample, now these kind of information comes in when you have those true or false questions, like which of the following statements is true and which of the following statements is wrong. In that, these facts come in handy. So when we take a sample of cervical screening test, around 80% are positive for any sort of HPV DNA. Okay. Out of which 2% have 16 or 18, which is a high-risk virus. 6% have other viruses. And vaccine lowered the chances, but vaccine does not make the chances to be 0. So these are all 4 statements which are very helpful when you're doing the questions regarding true or false. Now, what is the, how do we interpret the cervical screening test? How do we interpret the pathway? So suppose a patient has come, you have done a cervical screening test. Now what all can happen? One thing is HPV is not detected. If HPV is not detected, you send the patient home and ask them to come back after 5 years. Okay. Second scenario is if you have an inadequate sample, you call the patient back within 6 to 12 weeks, schedule another CST. So these are 2 clear pathways. They will never ask these questions. These are 2 clear pathways. They will never ask these questions because they are too easy to handle. Now let's see if it is HPV 16 or 18. In that case, irrespective of LBC, LBC is liquid-based cytology. What happens is you do a swab, you check for HPV DNA. If any HPV is positive, they will do a reflex LBC. They will do a reflex liquid-based cytology. And they will try to assess whether the changes in the cellular morphology of the cervix is low cell or high grade lesion. So what kind of lesion that is? They will try to assess that, or no changes at all. So out of these, any scenario can happen. But if it comes out HPV 16 or 18, then we go directly for colposcopy. Okay. If it comes out for any HPV, but not HPV 16 or 18, then we go for a liquid-based cytology. Now here 2 things can come out. It can come out as HSIL or it can come out as LSIL. If it come out as high grade lesion, we again go for colposcopy. So far we know that in two scenarios, in HPV 16 and 18 and in high grade lesion, we go for colposcopy, right? Any HPV which is not 16, 18, we do a liquid based cytology, and if it does not come out to be HCIL, if it come out to be LCIL, then what do? We call them back after 1 year, because usually these lesions regress. Now after 1 year, now again, all those scenarios can happen. We have taken a CST, the patient might not have HPV now, the patient might not have an inadequate sample, but we know what to do in those scenarios. Now after 1 year, if it comes as HCIL, then we again go for a colposcopy. But if it comes back LCIL again, we again send them back for 1 year, right? And again, if it comes out as HCIL, then we go for colposcopy. Now, if it is come as LCIL, now we have tested the patient twice. We have to look at certain scenarios. For example, if the woman is more than 50 years of age, if she is immunocompromised, if she belongs to that Aboriginal community, okay, or if she has gotten delayed. She was supposed to come in 2024, she came in 2026. She got delayed. In all these cases, we again go for a colposcopy. If in any scenario the patient is symptomatic, if she has discharge, if she has bleeding, if she has post-coital bleeding, if she has pain, if she has bulging uterus, any symptom, sign and symptom of gynecology, we go for a colposcopy. Okay. So I hope I'm clear till now. HPV not detected, routine recall after 5 years. HPV is there, 16-18, colposcopy. HPV any other than 16-18, we go for a cytology. In the cytology, if it is HCIL, colposcopy. If it is any other, if it is LCIL, we repeat after 12 months. Okay. Now let's look at the chart. This is what you had to know about colposcopy and cervical screening test. Now let's look at the chart. What does the chart say? Okay. So see, HPV detected, which is not 16 and 18. Okay. HPV detected, which is not 16 and 18. We go for a reflex LBC. In the reflex LBC, if it is unsatisfactory, always call back 6 to 12 weeks. So unsatisfactory, 6 to 12 weeks. Unsatisfactory, 6 to 12 weeks. Not detected, routine screen after 5 years. If it is negative, then repeat after 12 months. If it is LCIL, repeat after 12 months. After 12 months, we again go through this whole chart, and in special scenarios, which are women more than 50 years, Aboriginal or Torres Strait Islander, women who is overdue for screening, in all these cases, we go for a colposcopy. Okay. Now there are certain special situations. What are those special situations? Is my screen visible? Whatever I've shared? Okay. Okay, right. Thank you, Mandeep. So now what happens if this HPV is detected in a pregnancy? So if HPV is detected in a pregnancy, then what can you do? If the sign and symptoms are not present, then we go for a second trimester colposcopy. But if the sign and symptoms are present, then we go for a anytime colposcopy. Like if the patient has sign and symptoms, then as soon as she comes, we go for a colposcopy. If the patient is immunocompromised, I told you that we have to do a 3-yearly screening, and any HPV, we do not go for LBC, and irrespective of whatever the LBC is, we directly go for a colposcopy. So if this is an if this is an immunocompromised patient here, if this is an immunocompromised patient here, this one, HPV is detected, but it is not 16-18, then we go for a colposcopy directly from here. We do not wait for LBC, and we do not look at LBC like what LBC is saying. Now, what is the post-treatment surveillance or test of cure? Test of cure is done for patients who have some cervical abnormality already detected. For example, if we have HCIL, if we have CIN2, CIN3, or early stages of cervical cancer, in all those cases, we take out the cervix, or we do a cone biopsy, or we do some sort of surgery, or we do some sort of other treatment. In all those cases, we call the patient after 12 months. Here we do a co-test. What is a co-test? Co-test is this. Co-test is DNA plus cytology. Okay. We do a co-test. If the co-test is negative, we call the patient back after 12 months. Here we do only DNA. If the DNA is negative, then we put the patient back on either surveillance, the routine 5-yearly surveillance, or if the patient is immunocompromised, we put them on 3-yearly surveillance. If the patient has uterus removed for that condition, then we do the vault testing for 2 years, and then we put the patient back on surveillance, and we stop after 2 negative tests. You'll find it better when you will do the MCQs. So now I need a volunteer. Someone raise their hands. I want a volunteer to read the question and do that question. Come on, guys. Anyone? We have so many people here.
Yes, ma'am.
Okay, Dr. Farhan. Very good. So please read the first question and tell me what your answer is. Dr. Anusha, Dr. Hamza, someone please volunteer.
I can volunteer.
Yeah, sure, maybe. Why not?
Okay.
Yes, please go ahead, Dr. Ruth. Yeah.
A 45-year-old woman attends your clinic and is due for routine cervical screening. She says pap smears have been very uncomfortable for her in the past and she is hesitant. She has no symptoms. According to the current National Cervical Screening Program, which of the following is the best approach? A. Reassure her she can safely wait another 5 years since she's anxious, as screening is optional. Perform a pap smear instead of the HPV test, as it might be less uncomfortable for her. Offer her the option of a self-collected vaginal HPV sample under your supervision. Explain that self-collection is only available to women who haven't screened in over 7 years. Keep the speculum exam and perform an HPV test on a urine sample instead, as this is part of the program. I think the answer is C. Offer her a self-collected sample.
So any doubts in this question? Because I told you there are 2 methods of sample collection and both are equally approved. Both have equal sensitivity, both have equal specificity, and there is no bias between the two. So they are equally effective and a patient can use any one of the methods. The only contraindications to a self-collected vaginal swab are when the patient is having some symptoms or signs, when the patient is pregnant, when the patient has a history of past adenocarcinoma and has been treated for it, and if the patient is undergoing test of cure. So the patient has been treated, you are calling her back after 12 months, you are doing the co-test, she's not allowed to take a self-collected vaginal swab. You will do that. And again, when after 1 year she's coming for a swab, then the patient can do a self-collect specimen, right? Okay, someone else please volunteer. Come on, come on. Who is this? Dr. Anusha, Dr. Azhar, can you please do this question?
ما نقصد الصيام الا اذا في موعد قلبين انظر لا لا هذه عاديه لا لا عاديه ما يخالف
Am I having someone to complete this question, like to answer it?
A 40-year-old woman has a communication-collected cervical screening test. Her previous screen diet present oncogenic disease undetected. But still negative for epithelial
People are answering the chat. I want to interact with someone. Can someone just read it out and just answer me and tell me why the answer is B?
May I read it, ma'am?
All right, the answer is B. Why the answer is B? Because we have HPV 16 detected, and doesn't matter what the LBC says, we have to go for a colposcopic assessment because there were two strict indications for a colposcopy. One was HPV 16 or 18, and the second was high grade squamous cell cervical lesion. Someone has opened two tabs. Please close one of your tabs. I'm getting my echo back. All right. So the answer is B. Let's move to another one. Someone can please volunteer and read the question out and give me the answer.
Yeah.
Dr. Akia, Dr. Farhan, Dr. Anusha, Dr. Hamza, someone please volunteer. Dr. Hamza, please do this question.
A 34-year-old patient was treated with LETZ for a histological. Ma'am, as she is
This is the
HCIL,
procedure done for the zone, transition zone.
yes. As she is HCIL high-grade intraepithelial lesion, we are doing colposcopy damage management.
Yep. So what is your answer? Please put your answer in the chat box.
Oh, okay.
The answer is D. Annual co-test every year until 2028. Okay. Anyone else?
Why not E, ma'am?
Why not?
E.
B. Someone is saying B. Okay. Give me your like logic. Someone has said C. Give me your logic, please.
I think it's
guys. This is a discussion, so you can speak. Yeah.
I think it's C because it's only 2 negative tests, not 5 years of negative tests, as D says. So I think it's C.
So we learned that we have to do test of cure, which is also called as post-treatment surveillance. So the patient has been treated for a high-grade lesion, CIN3. I told you there are certain indications for test of cure, which are HSIL, CIN1, CIN3, CIN2, and early stages of cervical cancer. For all those treatments, we have to perform a test of cure or post-treatment surveillance. Now, the post-treatment surveillance requires 2 yearly follow-up. So 2 yearly follow-up, annual follow-up for 2 years. So we call the patient back after 12 months. We do a co-test. In that co-test, we do the DNA, the HPV, as well as the cytology. But the second test that we do is not a co-test. We only do DNA. So she was treated in Jan 2023. We called her back after 1 year in Jan 2024. Here we did a co-test. Now we are calling her in 2025. in 2025, would she undergo a HPV only, or would she go a complete test of cure, which is 2 negative co-test? No, it is not 2 negative co-test. It is 1 negative co-test, which is done in the first year of follow-up, and a HPV test without cytology in the following year. So the answer would be B. Any doubts? The answer is B. Any doubts in this scenario, in this question? If 2 tests negative, what will be the new management? If 2 tests are negative, then the management will depend upon if the patient still has a uterus or not. For example, if the patient still has a uterus, she will be put on a routine 5-year surveillance. So 2 tests negative. First test is a co-test. We did a HPV DNA, we did a LBC, both came out negative. We called her back after 1 year. We did HPV DNA, it came back negative. If the patient still has a uterus, she will undergo the 5-yearly surveillance till the age of 74. If the patient does not have a uterus, then that means we did the 2 tests on the vault of the vagina, not on the uterus. We did the tests on the vault of the vagina. We did a co-test first on the vault of vagina. We did HPV DNA on the vault of vagina. Now it is negative. We do not need to call this patient further. Any other question in this scenario, or should we move on to the next question? All right, so I want a volunteer for this one. Someone please read it out and tell me what is the answer.
Hello.
Hi.
Sorry. It says you see a 28-year-old patient who is 16 weeks pregnant with her first baby. Her last pap smear was at age 23. According to records, she never had the new cervical screening test and is overdue. She has no symptoms. What do you recommend regarding cervical screening in her situation? A. Defer any cervical screening until after she delivers because sampling in pregnancy is contraindicated. B. Perform a CST now during pregnancy. That's clinician screening test now during pregnancy. It is safe using a speculum exam, but avoiding the endocervical brush. C. Offer her only self-collection now because clinician collection is unsafe in pregnancy. D. Wait until the 3rd trimester to do the clinician sample testing as screening is safest late in pregnancy. E. Advise that since she's under 13, it's optional to screen. She can decide after the baby is born. I think the answer is B. Perform a
Yes. Yes, very good. So the answer is B, because in pregnancy, we can perform a CST. The patient is 16 weeks pregnant, which means she's in the 2nd trimester. The patient is 16 weeks pregnant and she's in the 2nd trimester, and 2nd trimester is absolutely safe for CST. So we perform a CST now. It is safe. We just avoid the endocervical brush so as to avoid bleeding. Why not delay? Because we never delay cervical screening when the patient is symptomatic. Okay. And offer her any self-collection now? No, because clinician collection is actually safe in pregnancy. Pregnancy was one of the indications of clinician collected sample. Why wait under the 3rd trimester? We know that 2nd trimester is safe for pregnancy. This is not a correct option because we do cervical screening test from 24 to 70 years of age. All right. Next, someone please volunteer.
Let me go again, can I? Or someone else?
Yeah, sure, why not? Oh, please go ahead.
A 26-year-old woman was diagnosed with HIV 1 year ago. She's on treatment with a good immune response. Her cervical screening history is incomplete. She had one pap at 21, which was normal, and nothing since. According to the NCSP guideline for immune deficient women, how should her cervical screening be managed moving forward? A, she should start screening at age 30 as HIV positive women begin later due to lower HPV transmission in monogamy. B, she should have a clinician screening test now after her HIV diagnosis. And if it's normal, continue screening every 3 years. Continue screening every 2 years rather than 5. C, she can follow the routine schedule for the general population. Next CST at 25 and then 5 yearly because her HIV is well controlled. D, she should have a co-test every 12 months indefinitely because of HIV. E, if her initial CST is HPV positive, any type, manage it as this, manage it the same as any other patient, in bracket, colposcopy, only if H16 and 18 or high-grade cytology. So I'll say that the answer is B. She should have a CST now.
Yes, she should have a CST now. And if it is normal, then we continue screening her for 3 years rather than 5 because the screening guidelines for immunocompromised patients is different. These are high risk and need a modified screening regime. The guidelines state that women 25 to 74 with a new HIV diagnosis should have their screening history reviewed as she is overdue. She was she had to have a CST at 25, but she did not. So she should be screened right now. And if any HPV is detected, she should undergo a colposcopy straight away. If no HPV is detected, whether oncogenic, non-oncogenic, if no oncogenic HPV is detected, then she has the interval of 3 years rather than 5 years, which is for normal people. Okay. So the answer is B, because we have to screen the immunocompromised patients every 3 years, not every 5 years. Okay. Right. Next one. Someone else. Some volunteer, please. Dr. Monica, Dr. Nathani, Dr. Neelam, Dr. Fanny, Dr. Ruth. Dr. Ruth, can I call you back again, please? You want to do this one?
Yeah, a 42-year-old chose self-collection for routine screening. Result, oncogenic HPV detected, not 1618. She is asymptomatic. Next best step. Recall for a clinician collected cervical sample for LBC cytology within 6 weeks to triage. Book colposcopy immediately regardless of cytology. Schedule repeat HPV test in 12 months without cytology, repeat self-collection in 6 weeks, give HPV vaccine now to treat the infection. I think it would be A. Recall for a clinician collected cervical sample for cytology.
Okay. Does anyone have a different opinion?
Well,
All right, Dr. Ruth, see, what happens is that this patient did a self-collection, and we know that self-collection is absolutely comparable to a clinician collected sample. Okay. There is no difference in terms of sensitivity or specificity. We know that this has come back positive, HPV 16 and 18, and we know that there are two absolute indications for cytology colposcopy. One is if there is HPV 16 or 18, and two is if in the LBC, if in the reflex LBC we have HSIL. Okay, all these two conditions are absolute conditions for a colposcopy. So once oncologic HPV have been detected, there is no point calling this patient back again for another test. We directly book her for colposcopy without even trying for LBC. We do not need the LBC report. If it is 16 and 18, we directly go for a colposcopy.
but this is not 1618. It says oncogenic HPV, then it's not
Sorry.
1618. It's a
This
bit
is my
confusing.
error. Yeah. This is error from my side. This is 1618 actually. Sorry.
Okay, then
This
that's
is
the
my
reason.
yeah.
Yeah.
Sorry, this is my error. Okay. You can do this one.
Okay, this is a 33-year-old renal transplant recipient on tacrolimus had clinician collected as CST, HPV detected, not 1618, LBC negative. She is asymptomatic. Next step. Repeat HPV in 12 months. Refer for colposcopy now. Routine 5-year recall. Offer self-collection next time to reduce speculum exams. Begin annual co-tests indefinitely. So HPV not 1618 and LBC is negative. They repeat in 12 months.
But the patient is immunocompromised, right?
Oh, that's true. Yeah, that's true. She's on tacrolimus, yes, immunocompromised. So would be
So
refer for colposcopy now.
yeah, because every immunocompromised, no matter what kind of HPV is detected, whether it is oncogenic, not oncogenic, in all those cases, we refer them for colposcopy directly
Yeah.
because these are high-risk individuals. Okay. All right. I love you, Ruth. You're too good. So if anyone else is not doing, then I'll ask her again to do this one more question because you people are too bad at volunteering. And this is not the way it goes. If you take these classes and you are in my classes, you'll have to put your cam and your mics and you'll have to interact. That is the way to go. If you don't discuss it out here, if you don't do mistakes here, you will do these mistakes in the exam. So please volunteer. Please do make mistakes here. It is very important to make mistakes here. That is how you will understand all those little knickknacks of the exam. So someone please attempt this question. iPhone, can you please read it out and tell me what's your logic behind answering A? Okay. Okay, fine. Put your answers in the chat box at least. Dr. Monica, Dr. Lydia. DES is the drug which is responsible for cancer of the vagina and cervix, which it is called desethyl. Desethyl. There is that
Stilbestrol.
dithylstilbestrol. Dithylstilbestrol, yes. So this is that drug which is it causes complications in the pregnancy also, and it is associated with cancers of vagina and the cervix in the later part of the fetus's life also. The fetus's life also. So if the patient has been exposed to DES in utero, how would you like to screen this patient? Please volunteer. Someone say something. Give me your thoughts. What do you want to say about this question?
Can I go?
Yeah, sure. Why not?
Okay. Should I just suggest my answer, or should I read the question?
No, you just tell me your answer. We've read the question.
Okay. I think it's B. Annual
Yes.
specialist-led cytology and colposcopy.
Yes. So we do annual specialist-led cytology. These patients are not allowed to do a self-collection. The collection has to be done by the specialist, and we do a colposcopy irrespective of whatever comes out in the test, because these have very high chances of cervical and vaginal cancers. So the answer is B. Dr. Kanayo, can you do this one also?
It says exit test 7074 returns HPV positive, not 1618. Okay, sorry about that. A 72-year-old present for exit screening. Clinician screening test. HPV detected, not 1618. LBC negative. She is well. Next best step. A, return to routine 5-year screening. B, refer to colposcopy. Colposcopy. Any HPV plus at exit warrant specialist assessment. C, repeat HPV in 12 months. D, discharge from screening due to age. E, self-collection in 6 weeks for confirmation. I think I'll say C.
You want to repeat
HPV
in
in
12 months. It seems a reasonable answer that she has to come back after 12 months, because that is what we do for all the cases when the
Yes.
LBC is negative and the HPV is not 1618. But when we are talking about the ages 70 to 74, and we know that the patient is having an exit test, this is the last cervical screening test. We want to do a colposcopy. Doesn't matter what kind of HPV she has come with. Exit test is done. I mean, an exit is allowed. I'm sorry. So we allow an exit only when the co-test is negative. Only when the HPV is not detected. And that is only when we allow the exit test. If any HPV is detected, then we arrange for a colposcopy in these patients, because After this, the patient is not going to come back. And if she has an HPV right now at the age of say 70, 71, 72, we are not sure she'll be healthy. Okay. So we want a specialist assessment at this point of time. Okay. Anyone?
Okay, sorry about that. Sorry, I have a question.
Yes.
Okay, concerning the last question, but then she's 72, she still has 2 years to go since the screening test is between 25 to 74. So if we do a repeat test in 12 months, she can, at that time, the HPV could be detected for 16 and 18. It could be detected at that time, and then, or something could change between that in the 12 months period, something could
Yeah,
change,
I
and then
know. It
we
seems, yeah,
do a colposcopy at
it
that
seems
time.
logical. Exactly. It seems logical that we can call her back after 1 year, but she has come here for exit screening. This is a last cervical screening test. Any HPV detected, we are not going to take chances. We'll go for a colposcopy. This is an exception to the rule.
So, hi, if let's say patient comes after 74, we don't do any tests, you mean? So the cutoff is 74 years old?
The cutoff is 74 for asymptomatic patients who had their exit screening negative for HPV as well as LBC. The cutoff is 74 for any patient who had their HPV and LBC negative before 74 in the exit screening.
All right, got it.
Any age, if the patient is symptomatic, we have to do a colposcopy. We might not even do a cervical screening test there. You
So
understand?
any screening positive, regardless of the age, we proceed the needed, right?
Yes. During the exit screening, in the last test of that patient, if she has any HPV, regardless of the oncogenicity of that virus, she has to undergo a colposcopy because she's 75. She's more prone to having cancer at this stage.
All right.
So the exit test warrants specialist assessment. Yeah. So who was talking to me right now? Can you please do this one?
All right. I may try. 62
sure.
years old, had a total hysterectomy for fibroids, no history of SIN and benign histology. She asked if she needs PEP test. Best advice. I would go for a, because she don't have a uterus, right? She did a total hysterectomy. So maybe I go for an E, colposcopy now to confirm no residual risk. Not sure about it.
Okay. What is colposcopy?
Hello?
What is colposcopy?
Sorry.
What is colposcopy? What exactly is colposcopy? How do we do colposcopy? So if your answer is E, that we want to do a colposcopy now to confirm the residual risk, what is colposcopy? And what is done in total hysterectomy? What part of body is removed in total hysterectomy? That is how you will arrive at your answer. Okay, let me explain it. Total hysterectomy is where we remove the uterus as well as the cervix and some part of the surrounding tissue, and we close the vaginal vault. So there is no cervix left. There is no cervix inside the body. We have taken it out. What is colposcopy? Colposcopy is when we target the cervix, we put some dye over the cervix, which stains the abnormal cells. And we look at it from a microscope and we take out those abnormal cells. We take a sample from the abnormal cells. That is colposcopy. So colposcopy is a very directed biopsy from the cervix. In the total hysterectomy, we have taken out the cervix. So colposcopy has no role after the cervix has been removed. So E is not the answer. Now change your answer to some other option. Whom I was talking to? Who was talking, doctor?
Sorry, Dr. Nandini here. I had a patient in
Dr.
between. Sorry, I had to go mute because of that. So now I got it. Okay. Maybe no further cervical vaginal screening is required since hysterectomy is done.
Yes. So now the patient has come back as no history for CIN and benign histology. The cervix has been removed,
Okay.
and the cervix has been removed. So we do not require any cervical or vaginal screening. If this patient has a history of CIN3, if this patient had a history of CIN3, then we would do a test of cure on the vault.
Yeah.
So first test on the vault, we will do a co-test. Call her after 1 year. We'll do a HPV DNA. If that came out negative, we will stop screening her further. Okay. If this was not total hysterectomy, if this was subtotal hysterectomy, if we had left the cervix inside and there is no CIN, there is no benign, the histology was benign, then we will put her on a 5-yearly screening indefinitely. If the cervix is left behind.
But could you please repeat again? Sorry. If let's say it's a CIN positive.
If the CIN was positive, if the patient was treated by subtotal hysterectomy for a CIN positive, subtotal hysterectomy, the cervix is left behind.
Okay.
Okay. Then we put her, and it was CIN3. So she would have to come for test of cure again. Test of cure, we will call her for 2 years. 1 year, we do the co-test. 1 year, we do the HPV DNA. If both come back negative, then we put her on surveillance, the 5-yearly routine surveillance.
All right.
Got my point?
Yeah,
if
yeah, I
it
got
was
it now.
subtotal hysterectomy, like cervix was left behind, yeah, but there is no benign histology in CIN. This is a different scenario. The cervix is there. We have removed the uterus, the cervix is left behind, but there was benign histology. There was no CIN. Then we do 5-yearly screening for the cervix routinely, and there is no test of cure required. You got the difference between the two?
Yeah, got it now.
Good. All right. So,
Excuse me, please. I
have
didn't
many
get
more
that
questions.
point clearly, please.
All right. See, test of cure is done yearly for patients who had been treated for any cervical pathology. For example, CIN2, CIN3, HSIL, or early stages of cervical cancer. All right. If after treating for cancer or HSIL or CIN, the cervix is left behind, it has to undergo a test of cure. Or if the vault is left behind, if total hysterectomy has been done, the vault has to undergo the test of cure. Now, in the case of vault, when the cervix is not there, we do a test of cure and we stop because there is no cervix. We do 2 tests on the vault for 2 years and then we stop. But if the cervix is left behind, then we do 2 years test of cure. When the test of cures come back negative, we put the patient on a routine 5-yearly surveillance because the cervix is still there. Anyone with a cervix has to undergo 5-yearly surveillance. Now, is it clear?
Thank you. It's clear.
Yeah. Okay. All right. Okay. So this is it for today. And this is how we teach. At least this is how I teach. So, and this is how you should read any topic for Australia. So you go into their websites. This whole chart, this whole topic has been taken from the Cancer Council website. These all questions have been prepared from the articles put up on the Cancer Council website. And when you do a topic, you have to read about the clinical problems that you will be facing when you will be a GP over there. So you are a GP and a patient comes back to you after hysterectomy. You have to decide what to do now. Whether to put her on surveillance, whether to put her on test of cure. So you need to know all those terms. All right. And these days, AMC is changing really rapidly. So it seems to you, it might seem to you that this is a recall from the cervical screening test, but a subtle change in the wordings will lead to a totally different answer. All right. So if there are any questions, then you please go ahead. Or
can you mention those bullet points which are necessary as a
bullet points of
MCQ's point of view?
Okay, so the
And a
bullet
quick
points for
summary
cervical
of
screening.
all these 11 questions that you have taught us today.
All right, see, for cervical cancer, first of all, what is the age group? It is 18 to 24, 24 to 75. When do we do it? Before 24, when the patient has had sex around the age of 14 or below before the age of 14 and the patient was not vaccinated. Okay. Then if we do it 5 yearly, except for in cases when the patient is immunocompromised, when we do it 3 yearly, and except for the patients who have had DES exposure, where we do it 1 yearly, and we do colposcopy. In immunocompromised patients, we do a colposcopy irrespective of the strain of DNA which is detected, whether it is HPV 1618 or non-1618. Then any HPV 1618, any HSIL, colposcopy. Sample not sufficient, 6 to 12 weeks. If the patient has no detected HPV DNA, call back after 5 years in normal conditions and 3 years in immunocompromised patients. All right. If the patient has HPV other than 1618 and the patient has LSIL or nothing on cytology, call her back after 1 year. Do it for 2 years. If it still comes back as LSIL, look at the age of the patient, more than 50, aboriginal, immunocompromised, or she's delayed her screening by 2 years, go for a colposcopy. Okay. Then if the patient has undergone a hysterectomy for a benign condition, we stop. If the patient has undergone hysterectomy for a cervical condition, for example, HSIL, CIN3, CIN2, early stage of cervical cancer, we do a test of cure. The test of cure is that we call the patient after 12 months. We do a co-test. We do HPV as well as LBC. Comes back negative, we call the patient again after 12 months. Here we do a HPV only. If this is negative this time also, then we put her on routine screening if the cervix is there, and we stop screening if the cervix is not there. So total hysterectomy, no further screening required after test of cure. Subtotal hysterectomy or the cervix is remaining, routine screening depending upon the immune status. If the patient is not immunocompromised, 5 yearly. If the patient is immunocompromised, 3 yearly. In pregnancy, we do it in second trimester. And yes, in pregnancy, we do it in second trimester. Okay, someone is saying this is very confusing. This is not at all confusing. I've tried to make it very clear, as clear as possible.
Okay. Sorry,
All
please,
right.
can I just have clarity? It's still hazy. Can I just recap what you said to be sure I had the point clearly?
Which points?
Okay, you mentioned that after total abdominal hysterectomy, that means the cervix and the uterus is taken off, and then the CIN was negative. The patient does not require any further examination.
Exactly. When the hysterectomy
Then,
is done for benign cause, we do not require to call the patient back. There is no test of cure
okay.
and no
Then,
screening.
then for subtotal hysterectomy with a negative CIN, we will have to do test of
We call
cure.
the patient for 5 yearly. 5 yearly. No test of cure.
No test of cure.
No. Anything done for a benign. See, test of cure has specific indications. It is HSIL, CIN2, CIN3, early stage of cancer. If those were not
Okay.
there, we have done a subtotal hysterectomy, routine surveillance, no test of cure.
Okay. 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 Thank you. It's clear. It's clear now.
Yeah.
Thank you.
Okay. So, if there are no more questions, then I'll hand over the screen and mic to the mid-exam expert people. They'll tell you about the course, how many days, what are the schedules, and you can chat with them. They've already put the WhatsApp, and you can contact
Thank
them
you, ma'am.
for
Thank you so much.
the enrollment and discount inquiries. I teach surgery and a few other topics, and we have excellent tutors. We have Dr. Nabeha, we have Dr. Zoya, we have Dr. Chinmay, and we have a wonderful team. And the results have been outstanding for the previous batches. I think you will have 2-3 sessions every week, which will be 2.5 to 3 hours each. And they basically cover everything from the recalls to the newer questions and the topics which are expected. Yes.
Can you request the team that provide us a informative webinar regarding AMC Part 1 and not Part 2, but Part 1 and the upcoming procedures of the Part 1?
I'm sorry, I did not get your question. Please repeat.
I said that can you request your team to provide us a informative webinar regarding AMC Part 1?
So what do you want to know about AMC Part 1?
Like the eligibility criteria, the exam questions, how they come, and the requirements, the examination fees, and the visa process, and after visa.
Yeah. So you have their number in the chat box, doctor. You can just contact them and they'll give you the whole brochure and they'll chat with you. You can call them also and they'll give you every detail that you need.
Okay, thank you.
Please go to the chat box, people. There is a link over there from people from MedExam Expert, and you can WhatsApp them and they'll talk to you and they'll let you know what are the requirements for AMC exam, what is the time duration, if it is available in your country or not, what is the fees and what is the eligibility, and if your college is eligible for AMC-1 or not, because the World College Register is there. Your college has to be in that register to be eligible for AMC-1, AMC Part 1. Okay, so just click on that link, send a hi, and they'll contact with you and tell you everything and help you with the application process, of course.
Excuse me, doctor.
So much.
Yes.
I don't know if we could just quickly go back to the exit screening question. I'm not very clear about. So obviously, if the patient between 70 to 74 has a negative no HPV at all test, then they don't have to come back for a recall. But in the question, I think the patient had HPV but not oncogenic strain. And then we said not to call her back in this case, but I didn't quite understand why not to call her if there is a HPV there.
No, the answer is refer to colposcopy. It is not calling her back.
Oh, okay.
Yeah.
Okay.
The answer is we refer her to colposcopy, irrespective of whatever HPV is detected. Even if it is not 16-18, we still ask her to undergo a colposcopy because she's at an age where she is more prone to that malignancy.
Okay. But then if it was no HPV at all, then we don't have to call her back again.
Yes.
Yeah, okay.
We tell her the red flags. Any discharge, any postcoital bleed, because she's 75, she's postmenopausal, any postmenopausal bleed, any discharge, any loss of weight, any loss of appetite, any lumps and bumps in the groin or in other parts of the body, she comes back.
All right. Okay.
Yeah.
Thank you so much.
Okay. All right. So my job is done here, and you can talk to the people of MedExam Expert, and they'll take it from there. Thank you. It was very lovely meeting you all.